Hi, everyone. Thank you for joining us this evening. I'm Kelly Hendershot at the Cancer Support Community. Welcome to tonight's live webinar. For those of you who are joining us for the first time, let me just tell you a few things about the Cancer Support Community. For more than 40 years, we have been a relentless ally for anyone impacted by cancer. We help individuals manage realities of this disruptive disease and get back to normal, whatever normal might be for them. Whether accessing our free services in person at one of our 190 worldwide locations, online, or even over our toll-free helpline, you're getting a team of licensed mental health professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and more. Today, we're going to discuss the gastrointestinal side effects or GI side effects of treatment for non-small cell lung cancer. I'm extremely grateful to have with us today an expert who helps us understand these side effects, their connection to the treatment for non-small cell lung cancer, and also shed light on support options and resources for everybody. So with me now, joining us now is Sandra Cuellar. She is PharmD, BCOP, FHOPA, FASHP, and is a clinical professor, a lot of credentials. So we're definitely speaking to an expert here. She is a clinical associate professor in the Department of Pharmacy Practice at the University of Illinois at Chicago, UIC, the College of Pharmacy, and a clinical pharmacist at UI Health. Dr. Cuellar received her PharmD degree from the University of Illinois at Chicago College of Pharmacy. She then completed a practice residency at the University of Kentucky Chandler Medicine Center. Following residency, she completed a specialty oncology residency at MD Anderson Cancer Center in Houston, Texas. Dr. Cuellar is the director of oncology residency program, a member of the DSMC, and chair of the IRB at UI Health. Dr. Cuellar is an editor at large for the Journal of Hematology Oncology Pharmacy and an invited lecturer to national organizations that include HOPA or HOPA, ASHP, ACCP, ACCC, and AMCP. In addition, Dr. Cuellar was recently appointed to be a member of the ASHP Commission on Credentialing and is past chair of the Industry Relation Council for Hematology Oncology Pharmacy Association. So Dr. Cuellar, we are very grateful to have you with us. Also thankful to the support from Mirati and partnership with Longevity in bringing you to this webinar today. So thank you for being here.
Thank you for the invitation, Kelly. It's my pleasure to be here, join you and your audience, and really share, my experience, my 20 plus experience in working with cancer patients. It's actually a passion of mine to talk about education and my experience.
And it's interesting to see your trajectory around the country. You've been where we have several CSC or Gilbus Clubs locations, so that's great to see. So Dr. Cuellar, I have some questions for you first, and then we're going to welcome questions from the rest of the audience. Audience, if you think of a question at any time, you can go ahead and put that in the Q&A and we'll have it queued up and ready for the end. But can you just start off by explaining to us what NSCLC is?
Sure. And I think that's, in oncology, we're very much guilty of using a lot of abbreviations, and it's like alphabet soup to a lot of people. So what NSCLC stands for is non-small cell lung cancer. Essentially, it's lung cancer, right? So what do we know about lung cancer is that if someone gets diagnosed with lung cancer, we then look at the cells, we take a biopsy, look at the cells under a microscope, and the pathologist is going to give us a category of what type of lung cancer it is. So you have lung cancer, we take a biopsy, is taking the tissue from the tumor or suspected tumor, looks at under a microscope, and then the pathologist will say, it's either cancerous or non-cancerous. And if it's cancerous, and it's, lung cancer, it's going to tell us what type of lung cancer. And there's two major categories or two types. non-small cell, and the other one is, can you guess? Small cell. So it's either non-small cell or small cell. The reason probably we're talking about tonight is non-small cell lung cancer. It's because about 80 to 85% of lung cancer cases are non-small cell lung cancer. So that's the majority of what we're seeing in our practice is non-small cell lung cancer.
So for that majority who have that non-small cell diagnosis, what are some of the common treatment options for them?
Sure. When we talk about treatment options for non-small cell lung cancer, the first thing we need to determine is the stage or the extent of the disease. So that's going to really put us on a path of what options there are. In general, treatment options consist of surgery, removing the cancer, radiation to the cancer, and then there's what we call systemic therapies. Systemic therapies encompass the medical drug treatments. And so that consists of chemotherapy, immunotherapy, and more of these, what we call designer targeted therapies. Okay, so really it's systemic chemotherapy, systemic immunotherapy, which is really one of our primary therapies, as well as targeted therapy, which usually come in the form of oral pills.
Okay. So and again, just for that breakdown, I think most in the audience are probably more familiar with chemotherapy, but again, just the difference between immunotherapy and targeted therapies, what that might look like.
Yep. So when we look at cancer and so what is cancer? So we'll just take a step back. Cancer is a mutated or abnormal cell that replicates uncontrollably, right? So it's constantly replicating. Chemotherapy is interfering with the cancer cell's ability to replicate at different stages of replication. Okay, so it's just like dropping a bomb on the cancer cell, and it's not very targeted or specific. Chemotherapy will affect any cell that's dividing. So that affects the cancer cell because the cancer cell doesn't know how to stop, as well as some normal cells, okay? Targeted therapy is really looking at what is causing the cell from a molecular level to proliferate uncontrollably, right? So there has been a lot of research involved to say, like, what's triggering this cancer cell to be in the on position? And so when we find that target, then there we can have drug therapy that targets that mutation. You'll hear a lot about that in non-small cell lung cancer. There are different types of mutations that occur, and each of these mutations can have a drug that targets that mutation, essentially turning off the cell's ability from replicating. Immunotherapy, on the other hand, works differently. So we know that cancer is, very adaptive and is very pro-survival. So it develops these really incredible abilities to maintain its ability to proliferate. So immunotherapy is what happens is our immune system is designed to seek and destroy abnormal cells, okay? And what happens is these cancer cells develop these mechanisms in which when our immune cell approaches the cancer cell turns it off. It inactivates the immune cell. Okay, so then that is what a physician here in the United States and a physician in Japan actually were able to discover how the immune system and the cancer cells interact and how the cancer cells are able to inactivate or turn off our immune system. They actually won the Nobel Prize for that. And so now we have immunotherapy as an option. Again, it's taking the brakes off of our immune system. It's not allowing the cancer cell to turn the immune system off. And then that way, if our immune system detects it, it's able to kill that cancer cell. So very exciting, very exciting. We are long past chemotherapy. It still remains the backbone in lung cancer, but now we have so many other treatment options. And it's really important for patients to understand, because sometimes we combine these therapies. We combine chemotherapy and immunotherapy, call it chemoimmunotherapy. So we're really trying to attack the cancer cell from multiple from multiple sides, so we could get the best outcome, right? Which is eradication, because
Sure.
these cancer cells have so many defense mechanisms, and if we kind of use all of our weapons that work differently, we think we can maximize cell kill.
Okay, so there's all these different treatment options, and we know unfortunately there are still different side effects with cancer treatment. So what are some of the more common ones for non-small cell?
Yeah, so unfortunately, our therapies do have side effects. Our chemotherapy has side effects, our targeted therapy has side effects, and even our immunotherapy side effects. So, in general, if I were to categorize some of the most common side effects that we observe with these therapies, we would say GI side effects. Again, alphabet soup. So, what is GI? Right? GI is gastrointestinal, right? So, and you can almost kind of tell what it means. It's gastro, your stomach and your intestine. But in oncology, when we say, oh, you're going to have GI side effects, really what encompasses GI is anything from the mouth, the esophagus, the stomach, the intestines, as well as the rectum. So it's your whole entire from mouth to rectum. Any side effects side effects can occur from mouth to intestine. And I think the most common that we think about when we think about GI side effects with oncology therapies is nausea and vomiting, right? I mean, that's kind of classic. That's the image we all get, someone that is having nausea and throwing up, right? And that's a common GI side effect that can be associated with primarily chemotherapy and to some degree targeted therapy. So, nausea, vomiting can interfere with patients' ability to eat or drink because they feel nauseous. It impacts their quality of life, interferes, with the multiple things, even their overall well-being.
Okay. So GI is actually quite a large area. I'm going to kind of start at the top a little bit. If someone's receiving treatment and they develop mouth sores or have a lot of pain, discomfort swallowing, what are some ways that they can manage those kinds of symptoms?
Yeah. So the side effect you're describing it has a couple of names. It's called stomatitis or mucositis. And again, so why do those side effects occur? So those occur, or where we primarily see that, is with chemotherapy. Why? It's because the cells in our mouth and in our GI tract are always replicating, they're turning over. So those cells in our mouth and in our gastrointestinal tract are sensitive to the effects of chemotherapy. So what it's doing, it's killing those cells in our mouth. And it's what's happening is you're getting mouth soreness, you're getting pain. Sometimes it's the most severe mucositis. It looks like hamburger meat. It's really tender and painful. And that can occur with some of our chemotherapy because, again, it's cytotoxic. It's non-discriminatory. Any cell that's replicating is sensitive to those effects. So the cells in the mouth, stomatitis, mucositis. So how do we manage that? That's a great question. I think the question, patients say, can I prevent it, Sandy? Is this something I can prevent? And in some situations, there's some data, and it's pretty benign and pretty easy, is if we know that a treatment can cause a high incidence, more than 25% of patients will develop stomatitis, we can say cryotherapy. What's cryotherapy? Ice chips. Very easy. And if there's anyone in the audience that watched Sex and the City, Samantha, when she had her breast cancer treatment, was had a popsicle in her mouth. Why? It's because coldness vasoconstricts the blood vessels in your mouth. So it limits the amount of chemotherapy that gets to your mouth. So that's kind of one mechanism of prevention. And then now we switch to treatment. How do we treat mucositis or stomatitis? There's a couple of things we can do. There are some oral lidocaine rinses that your pharmacy can compound. So it's like non-viscous lidocaine, which is a numbing solution in combination with a non-alcoholic mouth rinse, and like Maalox. And Maalox is good because it gives you that coating. It coats the mouth and you swish it around. And depending if you also have throat pain, you can either swallow it or swish it around and spit it. The other treatment we do is pain meds. Sometimes we need analgesics because it's painful. So we do some topicals. We could do systemic pain medications are some of our treatment. And I forgot to mention another thing for prevention. The other thing we counsel our patients, or when I talk to my patients in clinic that I know are likely going to develop this side effect, we always encourage good oral hygiene. So that's really critical, is good oral hygiene, soft bristle toothbrush, non-alcoholic mouth rinses. Why non-alcoholic mouth rinses? Because alcohol burns, and essentially your mouth is raw from the chemo, and that we don't want that to happen. So we'll say good oral hygiene. We'll recommend some salt and soda rinses. That kind of changes the pH in your mouth, and that tends to help too. And it's really easy. It's affordable. It's free, just salt and soda, salt and water, rinse it in your mouth. Could be also kind of like some, and good oral hygiene are some good preventatives. So when we think about stomatitis, we're looking at preventative initiatives, cryotherapy, good oral hygiene. And then once you develop it, we'll switch to topical mouth rinses as well as pain meds.
Okay. Yeah, that's a lot that can happen like in that upper portion. So kind of continuing down, you talked too about nausea and vomiting, which I think we all hear is this kind of more common for any kind of cancer. But what are some concerns if somebody's experiencing either of those, nausea or vomiting?
Yeah, that's something that is, we try to prevent. So we'll look at each treatment, and we already know the level of the risk of it causing nausea and vomiting. We'll also look at patient risk factors. So there's certain risk factors such as patients less than 50 are at higher risk for nausea vomiting. Women are at a higher risk for nausea vomiting. Patients who have a history of motion sickness are a history of nausea vomiting. So we'll look at the therapy risk factor as well as the patient's risk factor, and then determine what is a good supportive treatment plan to manage if the nausea vomiting occurs. And so we can give antiemetics. So antiemetics is a fancy word for anti-nausea drugs that patients can take before the treatment to prevent it. And then we give patients a take-home medication in the event that they have nausea vomiting once they leave the clinic, if it's like an IV treatment. So we have something as needed as well as something to prevent it. And in this class of anti-nausea drugs, we have a lot of different drugs that we can offer patients. Steroids, 5-H, Zofran, 5-H. There's quite a bit of options we can have. So no patient should ever have to suffer with nausea vomiting, because there's a lot of different medication strategies that we can implement and try to optimize so patients are have that controlled. Because when you have vomiting, right, you're not able to continue to eat and drink, and then that's when we get into another side effect, which is weight loss, and it impacts nutrition. And so that can get into, another challenging side effect with these cancer patients. So we really try to optimize our nausea vomiting medications before treatment, during treatment.
Mm-hmm. So speak up if you're having side effects.
For sure. For sure. Yes. Yes. Yes.
So for some more fun, you discussed bowel changes too. So what should people be looking out for?
Yeah, so diarrhea and constipation are both, when we think about, again, gastrointestinal side effects or GIs, that also folds into that category is diarrhea and constipation. And so again, depending on the treatment, it could be more diarrhea or it could be more constipation. I think what's important for patients is to really know what is their baseline, what is their bowel movements prior to treatment, right? Are they constipated at baseline? Do they already have loose motions? So kind of having that baseline. And then I think it's also important to define what is diarrhea. Sometimes people know or don't know. I'm like, well, what you're describing to me is diarrhea. right? So watery stools and multiple watery stools. So we can, depending on the treatment, if they're having diarrhea, the first important thing we're going to do is, we're going to give, take over the counter in general loperamide. I say in general because sometimes with immunotherapy, we would do steroids, kind of like something to blunt the immune response. But other than immunotherapy, we're likely going to give loperamide, which is a drug that's available at any Cornerstone drugstore. It's available without a prescription. It's called loperamide. It's an antidiarrheal, and almost always we just say follow the instructions on the box. And if it doesn't get better or it gets worse, you want to call us, right? And I think that's really important. You don't want to, because what happens with uncontrolled diarrhea, you could get dehydrated, your blood pressure can fall. In some pretty extreme cases, I've seen some acute kidney injuries because your kidneys dry up. And then now we're dealing with kidney problems, right? So diarrhea is something that we can manage, but it's important to really start antidiarrheal therapy. And in addition to that, what I like to counsel patients on is let's change it to your brat diet. So kind of just like we did when we were kids, right? So you're going to do bananas, toast, applesauce, those kind of bland foods until this diarrhea gets under control. And really important electrolytes, hydration. So because when you're having this uncontrolled diarrhea, you're losing fluid. So really we're recommending the brat diet. We're recommending fluids, the loperamide. And then really having an awareness if it's not getting better or it's getting worse, don't wait, 3 days to contact your doctor. You should, after a day, if it's not getting better after 3 to 4 doses and it's getting worse, you need to contact someone. So that would be something I would, recommend is really, again, I think communication is so key. And nowadays with these electric medical records, you can communicate online with your providers. So I think that's really, and I think patients, feel bad or we're bothering. No, we know, we expect it. We don't want you to go to the ER. We don't want you to be admitted to the hospital if we could try to prevent it. So early recognition and early management will lead to better successful outcomes.
It's one of the nice things about the EMRs too. You can do that as soon as you have the thought, send the message and not have to remember to make a phone call. And I apologize, I cut you off, but it's just very helpful to get that out right away.
The other thing I want to mention is, depending on how severe these side effects may be, nausea, vomiting, stomatitis, diarrhea, if it's moderate to severe side effects, and we have a system that we use that really kind of we grade the side effects, the doctor may say, let's hold the treatment. Let's wait till the side effect resolves, and then we'll restart it at a lower dose. Okay, so I think that's, again, a very key is that, with a lot of the drugs that I deal with, especially in lung cancer, I'm expecting patients to have a side effect. When I read the package insert or the side effects and it says like 70% have diarrhea, I'm expecting diarrhea, So it's important, for patients, with their transportation, where's the bathroom, or having an extra set of clothes. I mean, these are things that you don't really think about. But it's like, for me, it's like second nature. I talk about diarrhea every day. I talk to, at work, I do presentations at restaurants. I talk about diarrhea, but I've seen the dark side of diarrhea. So I don't want to minimize that. And there's a lot of things that we can do to manage it. But again, early recognition, early intervention, and communication are key.
Yeah, we used to joke that it's not a support group if you don't bring up food or bodily functions at some point.
I know. It's like, it happens. It happens. I mean, it's like second nature to us because we deal with, across not only with lung cancer, but across all of these other cancers that we see in our practice, breast cancer, colon cancer. A lot of these therapies cause diarrhea, I would say to a lesser degree, constipation. I think I see more diarrhea. If I were to kind of generalize, I see much more diarrhea. And then patients are just like, I don't want to take it. And I'm just like, oh, but just give me a chance, give me a chance, let me, we'll hold it. We'll get dose reduce it. We'll schedule it. You could take an antidiarrheal prior to each dose. There's so many mechanisms, but it's just a matter of communication.
So it sounds like a lot of these different side effects could either cause weight loss from obviously the nausea and the vomiting and the diarrhea, but it could also cause weight gain too. So what do you have for recommendations for people who either gain or lose weight as a result of their treatment?
Yeah. So I think one of the things is how profound, because sometimes we have to determine, is the weight loss or weight gain due to the cancer? There are certain cancers that are classic, known for cancer-related cachexia. Lung cancer is one of them. Pancreatic cancer is another. These cancers release these substances in our body that just kind of turn off your desire to eat. So I think one part is determining what's causing the change in appetite. Is it the cancer? Or is it our therapies, and is it our therapies directly, or is it the therapy causing nausea, vomiting, or, indirectly? So I think, really being able to determine the etiology or the cause of what's causing it is important. And then when we think about, nutrition, many cancer centers now offer a multidisciplinary approach. So what is multidisciplinary? Multi is many, and discipline is different areas of expertise. So for instance, you can have the medical oncologist, expertise is cancer. You can have a physical therapist whose expertise is in physical therapy, a pharmacist whose expertise is in drug management, and then the nutritionist is part of this team.
Mhm.
And so part of this multidisciplinary approach is referring these patients who may have changes in their appetite that's resulting in usually weight loss, but in some instances weight gain. And we refer them to nutrition, and nutrition will, do their workup and then provide their recommendations. So I think that's a vital part of our team, is our nutrition support healthcare providers. They can recommend, what diets, what recommendations of nutrition that pack in a lot of calories with a small amount, how to maximize, or someone with a tube, or someone who, can't eat with their mouth, or because they have esophageal cancer, or they have really bad mouth sores, or they are really trained, at least the nutrition support in the cancer center, are trained to see these types of patients and make really good recommendations. Yeah, they're vital to our team.
Absolutely. It's really important for anyone in the audience or watching this live, watching the replay, to see a nutritionist or a registered dietitian, ideally someone specific to oncology, even as before treatment starts, as soon as treatment starts. That's the same for getting to know a pharmacist, which I'll get to in a minute. But for some quick resources, we do have some material on our website about eating well with cancer. We also have a partnership with Saver Health, where we link to INA, which is their ability to text with a nutritionist or registered dietitian. So a few great resources. But pharmacists, I want to talk about them for a little bit. Do pharmacists tend to be fairly accessible to patients?
Yeah, so I would say at major academic centers, you will likely have pharmacist specialists like myself, where I am board certified, oncology residency trained to work side by side with other medical professionals managing cancer patients. So in an academic large medical center, I would say very likely. In community centers, I would say likely. I know here in the Chicago area, some of our community centers, Dooley, they have some oncology pharmacists that are just dedicated and trained to work with those patients. So I would first and foremost ask, your medical oncologist, is there a pharmacist I can talk to? And then your local pharmacist, I think they may not be know the medications as well as someone like, who is board certified and residency trained, because I live and breathe cancer drugs, right? And so your corner store Walgreens pharmacist may not, but they may be able to kind of help you navigate some of the questions that you have. So as far as to get back to your question, are pharmacists accessible? Yes. The type of pharmacist may vary depending on what type of medical oncology practice you're going to.
Great. So they can really make that connection between some of the side effects
Absolutely.
and do some education for you.
And that's what pharmacists, I mean, the majority of my position is talking to patients and educating patients on their cancer treatments because
Mhm.
they can be complicated. They have different schedules. They have different side effects. They have different, you have to have different medications that go along with these medications. And, it gets very overwhelming. And so as pharmacists, at our institution, they talk to the physician about the treatment, the nurse, but when they sit and talk to us, we really have that, ability to make it in simple terms and just really make it easy to digest because when you're first diagnosed or you just found out that you progressed or you had recurrence, there's a lot of emotional, things going on that you're not able to process this information. And so it's really nice that, after the physician, once you've had some time, then you meet with the pharmacist and the pharmacist can sit there, not only provide you with resources, online, paper, but then verbally sit down face to face and talk to you and answer whatever questions you may have. That's what we pride ourselves in doing. That's what we've been trained to do. And we enjoy doing it. We enjoy doing it.
Help decode a bit of that alphabet soup too.
Yeah, I know.
So can you explain to our viewers a little bit about what different support options and how they might differ could be available?
So support options, can you what exactly do you mean by support options?
As far as like who to reach out to on your care team, things
Oh,
like
yes.
that. Yeah.
Yes. So what I'm seeing more and more across cancer centers across the country, and I say that because as you described in my bio, I am a oncology residency surveyor. So I have go across the country, get to visit these cancer centers and for oncology pharmacy, but then I also know what kind of services they offer. And one of the things that is prominent are nurse navigators. And so nurse navigators, that role was really designed out of the demand of when a patient is getting diagnosed and they have to make all these appointments and it's a lot. It's like, oh, I have to go see the surgeon, I have to go see the radiation, I have to go see the medical oncologist, I have to go get labs, I have to go see the cardiologist, and the patient's like, when do I start treatment? What is treatment? So the nurse navigator really is, in my opinion, if you're in a lot of cancer centers now are hiring disease specific nurse navigators. So that would be my first go-to because they're really there to help that patient along their cancer journey is the nurse navigator. The second person I would go to is your mid-level. So what's a mid-level? A mid-level is like a nurse practitioner or a physician assistant. I think they're again working, sometimes they're a little bit more accessible than the medical oncologist is. And they can help navigate a lot of the questions, paperwork for insurance or for prior authorizations or things like that. So nurse navigators, your clinic nurse. So a lot of these providers have infusion nurses. Those are nurses that are administering the chemo, but
Mhm.
you would want to talk to the clinic nurse that again is working side by side with that physician. And if a pharmacist is a part of that team, really reaching out to the pharmacist, the social worker, the social worker is also very helpful in kind of helping patients navigate and, get their lives organized. Cause it's like, a lot of the patients we're treating are mothers, their sisters, their daughters. They have, their school, their job, there's a lot going on. And so really bringing in that social worker to help, I would seek them out too. So there's a lot of, personnel and healthcare professionals in these cancer centers that are there to really help navigate, answer questions, and make this journey as smooth as possible. And, with that said, a lot of the accreditations of the Commission on Cancer, when these cancer centers get accredited, they are really looking for those types of positions and recognize the value of what they bring for patients, because this is a really difficult part in someone's life. It's very disruptive. It's like your job, your full-time job is taking care of yourself and all these side effects. And unfortunately, some people don't have the luxury to give up, being a mom or being, a wife. They still have to manage and juggle all these things. So I think that over time, we're getting better at recognizing and implementing these resources to help patients.
So with all these different people on the care team, how do they determine what's the best option for each patient?
So in terms of treatment,
Yeah.
so that can
Treatment
vary.
or side effect management, since that's
Yeah.
primary.
So for treatment, I would say in institutions like academic centers and even community centers, there's something called a tumor board. So some cases are a little bit more challenging for a variety of reasons, and the provider will present their case, the patient's case, to a team of people, interventional radiologists, who, those for liver cancer, like, the interventional radiologist can take care of it. And the medical oncologist, like, no, I think chemo. And then the surgeon's like, no, I think I could cut it out. So you have this multidisciplinary healthcare from different, radiation, interventional radiologists, medical oncology, surgery, kind of come in, and everyone will discuss the best treatment at tumor board. And those are, I would say, the more difficult cases. The more straightforward cases, the medical oncologist is really driving those treatment decisions. And so the medical oncologist will say, you have this type of cancer, this stage of cancer. We also look at next generation sequencing, so kind of the tumor biology of things. And so the medical oncologist will take that all into account and make a treatment. Where, say, like, I come in is I make sure that there's no drug-drug interactions. I make sure that the dosing's appropriate, because sometimes the dosing needs to be reduced if the patient doesn't have good kidneys, right? Or their liver's not looking so good. So then I'll recommend, hey, maybe we need to reduce it based on this. Or, this patient had a previous hard time with nausea, vomiting. Maybe we should ramp up the nausea, vomiting meds. Mm-hmm. So the primary decision maker is the medical oncologist for systemic treatment. So the medical oncologist is going to make decisions on immunotherapy, targeted therapy, chemotherapy. The surgeon's going to determine whether or not they're a good surgical candidate, or if radiation's a good, or interventional radiologist. But the systemic therapy really boils down to the medical oncologist. Myself, I optimize. So whatever the treatment is, I make sure it's the right treatment at the right dose, and the right supportive care drugs. Make sure there's no drug-drug interactions, and we have all the baseline tests. So again, when we have these side effects, such as like diarrhea, or, I need to have electrolytes, right? So I need blood work, right? So I'm getting blood work before the treatment, and I'm monitoring the blood work after the treatment, right? So oftentimes I'm making sure that we're getting all the right labs that we need for these treatments.
Sure. So lots of expertise behind you.
Oh yeah. Behind the curtains, we are busy little bees that, it never ends. It never ends. It never ends.
So oftentimes in front of the curtain with the patient is their caregiver. So what can caregivers do to support their loved ones with non-small cell lung cancer and these potential side effects?
Yeah, I think caregivers are really critical with being with the patient. It's another person that's listening and hearing and understanding, helping the patient pick up the prescription, remind the patient to take the medication, because if they're not feeling well, they're fatigued, they're asleep, that caregiver is like, oh, here's your pill box. It's time to take X med. Remember what the doctor said, you have to take these every day, or, so that caregiver is there to help, help the patient when the patient may not always be at their 100%. So the caregiver can really facilitate with the medications, with recalling history, like, oh, because they will ask them, oh, what have you have any allergies or what has happened in the past? And the caregiver, really having the caregiver there to remember, to share the information is so critical and valuable. So they could play a really important part and sometimes help us explain it to the patients. I'll explain it and the caregiver gets it, but then the caregiver will say it to the patient and the patient's like, oh yeah, I get it now. I'm like, what? But yeah.
So let's fast forward a little bit. You're done with treatment. Does it take a lot of time for the side effects to subside after treatment?
The question is, it's like, it all depends on, after treatment. So if the medication is done, they're not taking the medication, then those side effects resolve, or if we stop, interrupt it, we would say it should resolve between 1 to 2 weeks. If it takes more than 2 weeks to resolve, then we're really questioning whether we should maintain that dose or we should dose reduce it or discontinue it. But the question of reversibility, that's a really good question is, are these side effects reversible, right? So that means after I discontinue the drug, will my mouth recover? And the answer is yes, your mouth will recover. It generally takes 7 to 10 days. The diarrhea with treatment should resolve within 7 days or at least improve over time. But I would say 7 to 10 days. Now there's other side effects, not GI related, that do take longer. Those tend to be like, and we're not talking about those, but neurotoxicity. So numbness and tingling in the hands and feet. That type of side effect can take 6 months to really reverse. But in terms of these GI side effects, nausea, vomiting, diarrhea, constipation, those are generally easy to manage with other medications or dose alterations, and they are reversible. And I would say within a week or so with a lot of these agents.
It's not too bad.
It's not too bad. Now, immunotherapy is always, again, the separate kind of adopted child, right? With immunotherapy, I think it's really important because we're using so much of it, is when I counsel patients, and part of our education is after we discontinue immunotherapy, patients can still develop immune-related adverse events up to a year after discontinuation. So it's always on our radar that could this been from their previous treatment, but that's pretty special to immunotherapy.
Okay. And do you have any general recommendations for patients once they've completed their treatment?
So once they completed their treatment, and so that's like probably like a curative patient, because patients with advanced disease or metastatic disease are usually on treatment, for life, So for patients who have completed therapy, and symptoms have resolved, they usually are now in what we call surveillance. So we're still kind of watching and monitoring these patients. A lot of them get referred to survivorship clinics. So really taking advantage of survivorship clinics and making sure that if there's any long-term toxicity, so long-term toxicity like from say cardiac or your kidneys. So we expect a lot of these side effects to kind of resolve, especially the GI ones, but some side effects that could affect your heart, your kidney, those need to be followed in survivorship clinics. So a lot of these places offer, and it's part of the credentialing for cancer centers, is survivorship. So that's where we would do surveillance and survivorship to follow these patients and see if they're recovering.
Great. I know at our own, we have a cancer transition survivorship program. We make sure that we talk about nutrition and some of these ongoing issues. For our viewers here, now's a great time. I see we do have some questions in the chat. Now's a great time to continue adding those. But Dr. Cuellar, before we go to the forum for questions, one more question for you. Is there anything else you want to make sure that our viewers know about GI side effects of treatment?
Yeah, so I think it's just really important to recognize that GI side effects can occur, and there are methods to try to minimize or prevent them, as well as to treat them. And if the doctor is giving you prescriptions or medications and says you need to take this to for 3 days after your treatment, it's likely something that we're trying to prevent. So really, it's really important to can be compliant with the medication regimens that your medical oncologist is providing you, because we're trying to likely prevent a side effect. And if a side effect happens, early recognition and early intervention is so critical. So communicating back to your nurse navigator, your clinic nurse, your pharmacist, your medical oncologist, calling that number or through the EMR, communicating, saying like, this is what's happening. And how I want to, I don't want to end up in the ED. I don't want to end up in the hospital. Is this something that we can manage? Because there are medications that we can offer patients to minimize, control, and manage these GI side effects that, again, can really cause patients to be like, I don't want this treatment. I feel pretty rotten. And we get it. We don't want you to feel rotten, but we have to find that happy medium of maybe the dose was too high. So let me try to control what's happening. Let's hold it, interrupt it, and let's restart it at a lower dose and then see how you do. But I think that we don't want patients to abandon really good treatments because we were not able to manage their GI side effects, which again, GI side effects, we have lots of different other treatments and medications to help with those GI side effects, in addition to reducing the dose.
Okay, great. And like you said earlier, the care team wants to hear the questions.
Absolutely. We expect it. I mean, we expect it. And we really want our patients to get the maximum benefit of medications. But if they abandon the medication because they weren't able to tolerate it, then it's like, okay, now what? We have to find something else. And maybe the medication we're giving you is really the best option. And we want to really not exhaust that, because there's only so many options that we can offer patients. And so we really want to maximize each treatment option because we know that that's the best treatment option.
Great. Well, a few more questions from you for the audience then, since we know that you like questions. Why are women more likely to have nausea and vomiting than men?
That's a great question. And so we not only see that women have a higher incidence post chemotherapy, this has also been observed post surgically that the incidence of nausea is higher post operatively in women compared to men. And we really don't have a definitive reason or scientific rationale. Some have speculated it could be hormone related. But we really don't know the exact reason. We just know that being a woman is a risk factor, or we as women are at higher risk for developing nausea, vomiting higher than men. And that's an established risk factor.
Unfortunate one. So this one has some specifics. So again, just reminders, you want to talk to your specific care team, but Dr. Cuellar, whatever you're comfortable answering, I'm eating regularly and still losing weight. What could cause this? I'm working with my care team, including a nutritionist. I'm on Tagrisso 80 and have completed the first year with the tumor shrinking. I was diagnosed in September 22, have had 32 radiation treatments along with chemotherapy at the same time with no effect on the tumor. I don't experience nausea or vomiting, but I do have occasional diarrhea.
Yeah, so that drug is osimertinib or Tagrisso. It's an EGFR, one of our kind of third generation EGFR TKIs, tyrosine kinase inhibitors. And so again, this is, remember what I said earlier is when we talk about cancer-related cachexia, the two, in my opinion, the two primary cancers that I see is lung cancer and pancreatic cancer. So part of it can be the disease itself. The cancer itself is releasing these substances in your body that you're just not, you're eating, but you're just not the weight is not sticking. What I will say is there was a fairly recent investigation or study that was published in a prestigious article. The prestigious article journal is Journal of Clinical Oncology. So that's a very prestigious journal that medical oncologists read. And there was a study that looked at the role of a medication called olanzapine. And lung cancer patients were involved in this study, and it really helped increase appetite, and they did see a weight gain. So I think that could be something that you can ask your medical oncologist about. Now, I will say that Tagrisso has a cardiac side effect, and olanzapine has a cardiac side effect. So there's some additional monitoring that needs to be done, but I think it's definitely feasible. But again, is it the drug or is it the cancer that's contributing to your weight and your nutrition? It's probably a combination of both. And so that's difficult because you're on a medication, it's working, but you still have the cancer there, and that may be contributing to that nutrition.
What might be our final question, not as many specifics, but similar. I'm losing weight, but I'm still eating routinely. What could be the cause of this? I am working with my team, including a nutritionist on this.
So do we know what type of cancer and how much weight is being lost?
Yeah, that came in as an anonymous question. If the person who wrote that could enter some more details or put that in the chat.
This is one of I would say, cancer-related cachexia, is probably one of the areas in oncology where we've made limited progress in terms of finding medications or solutions to try to, optimize that. We really don't have a silver bullet that we can offer patients. We used to offer this drug called Megace. In some patients, there is some data with THC or marijuana. There is some data in cancer patients that helps with the nausea as well as appetite. But does appetite result in increased weight? That's not there, right? So it's really like increasing appetite and weight gain. That's where we get the challenge with the data that we have with the pharmacological drug options, is that weight gain is not substantial enough. With this new article or this new study, relatively new, it's probably 6 months old now, they did see a weight gain with that particular medication. But this is an area, unfortunately, where we have made limited progress. And again, is it the drug or is it the disease, right? And as long as the disease is there, sometimes that's what's causing the weight loss and the decreased appetite.
Okay. And for those watching the recording and the live viewers, can you explain a little bit what cancer-related cachexia is? Just briefly, I know there's a lot to it.
Yeah, so cancer-related cachexia is essentially when you have a patient that has weight loss, and it's essentially weight loss, and they're not eating. They don't have an appetite, and it results in weight loss. So they are cachectic. So they're very thin patients. It's kind of like when you think of some cancers where they're very thin and they lose weight, it's because they have an inability to eat, or they have no desire to eat, and they're metabolic. They keep losing weight, and that's kind of a global term for cancer. That's what we call as cancer-related cachexia.
And what was the name of the study again that you mentioned a minute ago?
Yeah, so the journal is Journal of Clinical Oncology. And the drug that was in it, and I could probably provide it to you. If you give it, it's called olanzapine. The dose was 2.5 milligrams. So the physician can easily probably Google, JCO, olanzapine, supportive care. And it was pretty recent. Okay. But the key word is olanzapine. Now I'll tell you, olanzapine is a drug that we use quite a bit in oncology but another area uses it, which is psychiatry, because olanzapine is a mood stabilizer. But when you look at the mechanism of action and the neurochemicals that it modulates, it overlaps quite a bit in my oncology world. And so we now have adopted olanzapine as an anti-nausea medication. And then it's been investigated to not only be an anti-nausea, but nationally endorsed by several guidelines. But now this study is suggesting that it can also help with weight in eating. And it also will knock you out off your sleep. You're going to sleep like a baby if you take this medicine. We only tell patients to take it at night because you get zonked out pretty bad. So it's like, oh, it helps with nausea. Oh, it helps with sleep. Oh, it helps with weight. It's like, it's like our closest thing to a magic bullet. But we use it quite a bit. And it's like I said, it's nationally endorsed by national guidelines for the prevention and treatment of nausea, vomiting. But we also have emerging data that it can also help with weight and appetite. Okay, so olanzapine, Zyprexa.
One final question. How do you select a probiotic or prebiotic for managing gut health?
So that is an area that, for me, that is not part of the pharmacologic, medications that I use for gut health. So I would probably refer them to either nutrition or their PCP, because that's something that I'm not really comfortable recommending, because I'm not using those drugs. I'm not recommending. They're not a part of my guidelines. And so I probably couldn't comment on that.
Okay, that's fine. Great question to take back to your healthcare team. So I do want to make sure that everybody is aware, just if you want to hear more about this and you have a CSC or Gilda's Club in your area, we going to be offering workshops around GI side effects of non-small cell lung cancer this fall. So check out your local Gilda's Club or CSC calendar for more information. I do also want to make sure that you're all aware we do have a cancer support helpline. The phone number for that is 888-793-9355. We do have staff available to answer your calls Monday through Thursdays from 11 a.m. until 8 p.m. Eastern time. On Fridays, that's 11 a.m. until 6 p.m. Eastern time. So this helpline that I just gave the number for, it's staffed by community navigators, resource specialists. They have extensive experience in helping people affected by cancer, patients and loved ones. We provide guidance, resources, and support to cancer patients with a variety of different needs, from getting information about cancer, identifying a local support group, or just finding somebody who's going to listen. So Dr. Cuellar, thank you so much again for joining us today. This information and insights you've shared, without a doubt, they're going to be invaluable for our listeners. So thank you also again to our sponsor, Mirati Therapeutics, and our partner, Longevity. It's been my pleasure to have you join us today for this great conversation. And if you have additional questions about side effects, you're looking for resources about how to speak to your care team about them, or anything else that we discussed today, or generally about cancer, please connect with our experienced and licensed navigators at Cancer Support Helpline. Again, that number is 888-793-9355. You can also visit our website, cancersupportcommunity.org. So thank you, everybody.
Thank you, everyone. I hope you enjoyed and learned something from tonight's program. I appreciate it.